Hey guys, I'm Matthew Delaney. I want to talk today about some of my biggest childhood fears, and I've spent a lot of time thinking about this. I grew up totally afraid that as an adult, there were two situations I'd have to deal with on a regular basis. The first was quicksand, which fortunately has not been a big problem as an adult. The other one is rabies. And I think that I was traumatized as a kid by that horrible book and movie, Old Yeller, where it's a great story. It's a boy and his dog, yet at the end of the story, Old Yeller's attacked by a wolf that has rabies, Old Yeller gets bitten, and they have to put Old Yeller down, which is truly a horrible thing to read as a kid and has forever altered my relationship with dogs going forward. That being said, I don't see quicksand. I do see a lot of potential cases of rabies. So I was the other day dealing with a patient who thought they'd been exposed to rabies. And it raised the question of, do I really need to treat everybody who comes in with a potential exposure for rabies? I did a little digging, and I think the answer is probably we should treat almost everybody who shows up. Let me walk you through this. So when we think about who are the big players that can give patients rabies, we think of the Old Yellers, but actually dogs don't account for a large percentage of rabies exposures in the US. About 0.3% of cases of rabies come from dogs. We look at cats, it's 1.1%. So cats are actually a much bigger risk factor, but still relatively minor players. The animals we need to think about, the biggest offender in the US is going to be bats, then raccoons, then skunks, then foxes. So we kind of think about, is this animal likely to convey rabies to the patient that's been exposed? And then I kind of move on to what actually constitutes an exposure. So bites are easy. Even if it's from a dog or a cat, I think it's reasonable to have a discussion with the patient. Hey, the risk is low. The risk is not zero. But a bite, we at least say there's a reasonable chance you could have been exposed if this is an animal that's moderate to high risk. Here's where it gets a little bit tricky, and specifically when we're talking about bats. So with bats, they have small teeth, and the patient might not have an obvious bite. In fact, there's a really scary study that looked at fatal cases of rabies in the US in the last 25 years. There were 34 cases, and these were thought to be secondary to bat exposures. Only 8 out of the 34 patients actually reported, yeah, I was bitten by a bat, which is really scary if you think about it. And to make it a little scarier, 11 of the 34 patients who had a case of fatal rabies had no known bat exposure, but when they kind of did some stuff in the lab, they said, actually, this rabies came from a bat. So if a patient has any type of exposure to bat, or arguably if they say, hey, I woke up in a room, there was a bat in the corner, my go-to kind of based on this literature, and again, this is a fairly low level of evidence, but it's alarming. 34 cases of fatal rabies, in 11 of those cases, there was no known bat exposure. So if the patient says the word bat, I'm gonna have a serious conversation about, do we need to prophylax for rabies? So what do we do? How did we fail when it comes to prophylaxis? Because the rabies immunizations and the immunoglobulins are really effective. If we look at fatal cases of rabies where we tried to do something, when the patient slipped through the cracks, it's generally the wound was dirty, so we didn't clean the wound well, or we did an inadequate dosing schedule. We just didn't give them the right amount of stuff. And that's a problem I think all of us are susceptible to. There was a study that found that 40% of folks in the ED couldn't name the ideal rabies immunization schedule. I had to look this up. So it's really simple. If you're a healthy patient who's not immunocompromised, you get a shot of rabies immunization at day 0, 3, 7, and 14. But the other thing to remember is we want to hit them with rabies immunoglobulin, 20 international units per kilogram. And what that does is that basically protects them from rabies for the first 10 days after the vaccine while they build up antibodies. So this has really helped me make it a lot more simple. If it's a domesticated dog, domesticated cat that can be observed or has been up to date on their shots, I talk to the patient, hey, we could probably wait and see. We can monitor this animal to see if it shows signs of rabies. Beyond that, and specifically for bats, I have a very low threshold to say, hey, look, bats can be bad players. Cool animals can also give you rabies, which can kill you. Remember, you don't have to have a known bite. So day 0, 3, 7, 14, hit them with immunoglobulin. I think this is an easy one, low threshold to treat rabies, specifically around bats.
This is Hippo Education.